So let's talk about blood pressure. Now, when we talk about blood pressure, especially in a clinical setting, we're usually talking about blood pressure in the systemic arteries. We do that because you could take the blood pressure from anywhere in the body, from any vessel or even from within the heart. But the pressures are going to be different in different areas. For example, in the pulmonary arteries, pressure is much lower than in the systemic arteries. And a lot of that is because the pulmonary circuit is much shorter. So because of the less length, you have less resistance to flow, so you don't need as much pressure to get the blood to flow right. If you looked in the systemic veins, you would also find lower pressures for reasons that we're going to talk about. So just to keep in mind, we are going to be talking about systemic arterial blood pressure. Now, blood pressure largely depends on two things: how much blood you're putting into the arteries and how quickly that blood is leaving the arteries. So that's going to depend on cardiac output, which is how quickly blood is coming into the arteries, and something we call peripheral resistance, which is how difficult it is for blood to get out of the arteries. So just to sketch it, if you imagined we had our heart, and this was our artery, and then that's splitting up into many smaller vessels. This part is the cardiac output. This here is the peripheral resistance in summary. How hard is it, once you get blood into here, to get it out into the rest of the body? When we measure blood pressure, we're usually going to be measuring it here in the systemic arteries. So the two main things that affect that are how quickly we're putting blood in and how easy it is to get blood out. Now, let's start by talking about the cardiac output. So when the ventricles contract, and if we're talking about systemic arterial, we're talking left ventricle. When the left ventricle contracts, it applies pressure to the blood in there. And as we learned about when we looked at the Wiggers diagram in the cardiac cycle, when that pressure gets high enough, it overcomes the pressure that's already in the arteries, opens the semilunar valves, and blood starts exiting the left ventricle into the systemic arteries. That applies the pressure that the heart is applying to its blood to the pressure in those arteries. So if you were to draw a graph of systemic arterial pressure over time, you'd get something which would look like this. Where the blood rises to a high point. This is during ventricular ejection. So this is ventricular ejection. And then this is the rest of the cardiac cycle up until the next ventricular ejection. So during ejection, and if you remember, I'll try to show it on here, if you look at the Wiggers diagram and look at the ventricular pressure line, you can see it follows a similar pattern. Now here, during ventricular ejection, the pressure rises up to a maximal point. So that high point on the pressure chart is what we call the systolic pressure. In other words, the pressure that you get to during ventricular systole. And then, after that, the pressure falls off during the rest of the cardiac cycle, while the ventricles relax, down to a low point right before the next ventricular ejection, which we call the diastolic pressure in the heart. So you're familiar already with how those look in a clinical reading, probably. Let me just erase that. And so on a typical clinical blood pressure measurement, you might see something like 115/85. That's the systolic pressure observed, and the diastolic pressure. Now, something else I wanted to show you. Let me draw up again just a very quick version of a Wiggers diagram to illustrate something. Boom. And here, if you remember how the Wiggers diagram worked, you can see how our arterial pressure follows that same pattern. Drops, then during ventricular ejection rises up to a maximum, and then starts falling off again. On this picture, that would be the systolic pressure, and that would be the diastolic pressure that you would measure in the arteries. One thing to note, clinically, having these pressures be too low primarily means it's hard to get blood to your body. Too high is also interesting, though. If the systolic pressure gets very high, that means that during the high point in the pressure cycle, that blood is pushing hard on the walls of the blood vessels, which can cause damage over time, or even cause a rupture. But a high diastolic pressure is a little more subtle. The diastolic pressure is the low point you're going to get. That's the pressure that the ventricles have to overcome in order to open the semilunar valves. So if that diastolic pressure was high, the ventricles have to contract harder to open the valves at all to get any blood out, which means the heart has to work harder than it should. Having a high diastolic pressure over time causes the heart to have to overwork, which causes it to grow in a way, ventricular hypertrophy, which is not good for the way the heart should work. Also worth noting here is that while these are the systolic and diastolic pressure, there's another pressure of interest, which is the pulse pressure, which is the difference between them. Systolic minus diastolic. So in this case, that would be 30 millimeters of mercury. That's the difference between here and here. The pulse pressure. That's what you feel if you take the pulse. I'm feeling that rise in pressure in the artery in my wrist. Or I should be in a moment. Pretty sure I'm not dead. There it is. I'm feeling that bump in pressure. Now you may know that you can't feel the pulse pressure very well in veins in the body. In fact, you can't feel it at all. You have to feel the pulse easily. You have to find a place where an artery is close to the surface, like at the carotids, or the radial, or the femoral. One reason for that is because the pulse pressure decreases with distance from the heart. So let me erase this really quickly. No, actually, I'm going to leave it. Just sketch it over here. So if we looked in arteries, we find a high pulse pressure. But as I get further away from the heart, I see a change in the pressure pattern like this. So this is distance from heart. Here in the arteries, there's a big difference between systolic and diastolic. But as I get further away into the small arterioles and then into the capillaries, there's very little pulse left. Effectively, this bump in pressure goes into overcoming friction with the walls of the arteries. Plus, the overall pressure drops off as you get further from the heart. Now, if you've ever seen bleeding from different vessels, you've seen this very clearly. If I have an opening in an artery, the blood is under enough pressure that it will spray out of my body. Whereas if I open a capillary, like if I just cut my finger, it'll bleed, depending on what I cut, maybe even in a slightly pulsatile way, but mostly just bleeding. And if I open a vein, like for, say, a blood sample, the blood just kind of dribbles out. It's not under very much pressure. That's because the pressure mostly goes away as we get further from the heart. That has some issues with getting blood back to the heart, because, especially in the veins in the lower body, the pressure is kind of too low to easily push blood upward against gravity. So we'll talk about what our body does to overcome that in just a little bit here. Another thing that affects blood pressure is volume and distribution. So, all else being equal, how much blood I have in my body is going to affect pressure. So, for example, if I put more blood into my blood vessels, then overall pressure should be higher. There are things my body can do to compensate for that, but it tends to raise pressure. So let's talk for a moment about where you might get more or less blood. To losing blood generally comes from blood loss, although dehydration can also be an issue. So as you lose water from your body, whether that's loss of water for too much urination or diarrhea or excessive sweating even, or whether it's actual loss of blood, as the blood volume drops off, the blood pressure tends to drop with it because you don't have as much blood to pressurize your vessels. That is actually a very dangerous situation. If you're familiar with the idea of hypovolemic shock, so hypovolemic shock, hypo, low or beneath volemic volume, when you get shock from too little blood volume. In early hypovolemic shock, you tend to get things like rapid pulse, pale skin, clammy, meaning cold but kind of sweaty skin. These are all ways that your body is trying to compensate for the fact that your blood volume is low and so your pressure is low. If your blood pressure gets low, it's hard to get blood to your brain and heart, which are the only organs you absolutely must keep going moment by moment in order to stay alive. So these are compensatory mechanisms. When your blood volume gets low and your pressure drops off, you increase your pulse to try to push as much blood into the arteries as possible. You're increasing your cardiac output to try to get the arterial pressure as high as you can. Pale skin comes from the body constricting blood vessels in the periphery around the skin to try to keep the blood in toward the core, where it can be used for heart, brain, and other critical internal organs. You don't really need it in your skin and extremities at any given moment. Clammy comes from the fact that you're withholding that blood so your skin gets cold. It also comes from sweating, which comes from the sympathetic stimulation that you're using to try to keep your pulse rapid and things like that. But those are ways that your body is trying to compensate for that. The other thing you'll see in a person who is suffering from hypovolemia is that they get thirsty. They'll complain that they are terribly thirsty. And that's really their body saying, give me fluids. Give me something to add to my blood to bring my volume back up so I can maintain pressure. I'm no sort of paramedic, but my understanding is that when you arrive on the scene of a person who's lost a lot of blood, you don't wait for whole blood to infuse into them. You give them saline. Because more importantly than making sure they have enough red blood cells is to make sure that they have enough volume to pressurize their vessels. The other aspect that can affect blood pressure is blood distribution. So we've got, as we're going to talk about in a little bit here, arteries and veins and capillaries, different sets of vessels. But if we're looking at pressure in the arteries, if you allowed a lot of your blood to kind of stay in the veins to accumulate a lot of blood, that will tend to remove blood from your arteries and your pressure will be lower. Likewise, if you move blood from your veins back out into your arteries, that will tend to raise pressure. So another way that your body adjusts arterial pressure is by adjusting where the blood is tending to sit, arteries or veins. So if this blood pressure is so important, how is it that our body's going to regulate it? And there's several issues to consider here. We not only want to make sure that our blood pressure doesn't get too low, we also want to make sure it doesn't get too high. Too high and we damage blood vessels. Too low, we can't perfuse the heart and brain. So how are we going to regulate it in general and on a moment-by-moment basis? So we can talk about both kind of long-term and short-term regulation. So long-term regulation, meaning regulating our pressure over the scale of minutes, hours, days, more hours, days here, is largely a function of hormones. And mostly that's going to be hormones that affect how much urine we produce. Because when you produce more urine, that's removing water from the body. When you don't produce as much urine, you're trying to keep water in the body. So several hormones that we're going to talk about later, hormones like vasopressin and aldosterone, both influence how much urine we produce. Also, one called ANP, which is atrial natriuretic peptide, a hormone that your heart produces. All of these affect how much water you retain or release from your urinary system. Another hormone that can be involved here is angiotensin II. When we get into the urinary system, we'll talk a lot about about where we get angiotensin II. It has a lot to do with the urinary system, and it's another important hormone in regulating blood pressure, although that one is partially by regulating how constricted the muscle in our arteries is, which then affects our blood pressure. So long-term regulation is mostly hormones. Let's talk for a moment about short-term regulation. And by short-term regulation, I mean on the scale of seconds. And our blood pressure can change rapidly over the course of seconds. If I, for example, bend over or stand up, I need very different blood pressure to keep my brain perfused in this position compared to this position, standing up. Or if I laid down on the ground, I need even less pressure to keep my brain perfused. In fact, I don't want too much pressure because too much would then put my brain blood vessels in danger. On the other hand, if I then stand up, well, many of you have had the experience of what happens if you stand up too quickly. You end up with what they call orthostatic hypotension, as the blood drains away from your brain and you see the pretty stars, or maybe even lose consciousness. So how does our body adjust for the fact that our blood pressure goes up and down every time we change posture and change activity? Largely, that's a result of something called the baroreceptor reflex. So baroreceptor, baro is pressure. So these are pressure receptors. We find these take the form of stretch receptors in the walls of the carotid arteries and in the aortic arch. So stretch receptors here in the neck and in the arch of the aorta where it goes over the heart. These stretch receptors respond to how much pressure is in those arteries. The pressure in there pushes outward on the wall of the artery, and the stretch receptors detect how much stretch there is. They'll have a set point. They'll have a point which the negative feedback system here will consider normal. So let's imagine that I'm standing here right now, and my heart is putting out enough blood, enough cardiac output, and my vessels have the right tension to keep my pressure high enough that blood is getting to my brain very well. When the pressure is in that right amount, there's a certain amount of stretch in my carotid arteries. Those stretch receptors are feeding to my medulla, which is then talking to my hypothalamus about this, and indicating we have the right amount of stretch, we've probably got the right amount of pressure, all is well, everything's good. And then imagine what will happen if I lie down. So if right now I'm providing enough blood supply, enough blood flow to pressurize these vessels enough to get blood to my brain, but then I lie down, the same amount of cardiac output is now too much. Since I don't have to push blood against gravity anymore, now I'm sending too much blood up to the head when I lie down. So as I've laid down, now with that same amount of cardiac output, those vessels are now stretching even more as there's now too much blood coming to that area. That increasing stretch sends a signal to my medulla. My medulla says, oh no, the pressure is too high, the vessels are stretching out too much, we need to do something about it. And so then my medulla, in concert with my hypothalamus, will use my autonomic nervous system to reduce the pressure. So when baroreceptors detect increasing stretch, from that they conclude pressure is too high. So think for a moment, what would it make sense for them to do? Should they increase sympathetic activity or parasympathetic activity? If I were the medulla, would say that I should increase parasympathetic activity and decrease sympathetic. In general, sympathetic activity increases blood pressure by making the heart speed up and increasing the tension in blood vessels. So if my pressure is already too high, in order to bring pressure back down, I'm going to need to do these. Notice this is a negative feedback system. We have a sensor, our baroreceptors, an integrator, the medulla, with a set point that says this is the normal amount of stretch. If the pressure is too high, if the stretch is too high, then we use an effector, the autonomic nervous system, to bring the pressure back down, which will lower the stretch. You might even take a moment to try to write that up as a negative feedback system. Likewise, if the pressure is, if they detect decreasing stretch, say, for example, I laid down and my body adjusted for the fact that I didn't need as much pressure by lowering my heart rate and dilating my blood vessels. And now I decide to stand up, so quickly I stand up. Now, if I was providing enough blood pressure to get blood to my brain, but now that it has to go against gravity, that's not enough anymore. So now that blood starts to drain out of my head and I see the pretty swirling lights, and I get woozy. Think about what's happening to those stretch receptors. As the blood drains out of here, those vessels are now not under stretch. Now they're loosening up. So my baroreceptors detect decreasing stretch. From that, we conclude that pressure is too low, and we need to do the opposite. Increase sympathetic and decrease parasympathetic output. That will increase my pressure, push more blood back into those vessels, stretch them out more, and tell my medulla, okay, everything's good now. There's enough pressure to send blood to the brain. So that's the baroreceptor reflex. Normally, this works very well within about 1 heartbeat of a change. So the moment I stand up and my blood starts to drain away from my head, this responds instantly and restores blood flow. It doesn't always work, especially if you have low blood pressure in the first place. You may stand up and your pressure starts to fall, and before your baroreceptor reflex can quite kick in, it falls a little too low and you lose consciousness. Also, in older people, this tends to maybe not work quite as well, which is one of the reasons why they have to be a little more careful in standing up, lying down. Their blood pressure is not as well controlled.